Medic First Aid Basic is designed with an international audience in mind. When necessary, your instructor will provide advice, guidance, demonstrations, and course materials specific to the accepted skill practices and guidelines of your country. Welcome to Medic First Aid. Worldwide, for every second that passes, 10 people are injured. Every 10 seconds, someone in the world dies due to an accidental injury. Our ultimate goal must be to prevent these injuries and deaths by focusing on safe practices both at work and at home. However, once an injury or sudden illness has occurred, effective emergency care can often make the difference between life and death, rapid versus prolonged recovery, and temporary versus permanent disability. Your Medic First Aid instructor's goal is to help you gain or maintain the core knowledge, skills, and confidence necessary to provide effective emergency care until professional emergency medical care is available. Additionally, whether you are a novice or experienced first aid provider, we want your Medic First Aid learning experience to be as enjoyable and comfortable as possible. Your instructor will help accomplish this goal by creating a relaxed, low-stress atmosphere and by using positive coaching during skill practices. So once again, welcome to Medic First Aid. We're glad you're here. The Circles of Care concept explains and reinforces the simple priorities of providing emergency care. These priorities are to provide an open airway to the lungs, to ensure adequate breathing, and to maintain the effective circulation of oxygen through the bloodstream. The clockwise outer circle describes the steps of the initial assessment, which is an organized approach to a medical emergency. It emphasizes the safety of the Medic First Aid provider, the assessment of patient responsiveness, the activation of the emergency medical services system, and the assessment of the initial condition of a patient's airway, breathing, and circulation. The inner circles with the letters A, B, and C represent potential problems with a patient's airway, breathing, and circulation, and the specific care necessary to correct these problems. The inner circles also serve as a reminder of the critical balance between airway, breathing, and circulation. For example, if a patient's airway is blocked, breathing cannot occur. Once the patient stops breathing, circulation will quickly stop. Finally, the small circle with the letters OA in the center represents ongoing assessment, a continuous reassessment of the patient's airway, breathing, and circulation. This Circles of Care illustration will be used throughout this Medic First Aid course to help reinforce the priorities of care for ill and injured patients. Let's begin the course with a focus on initial assessment.
Hey, Mark, you need to go help that guy. He fell off the ladder.
Is it hurt bad?
Yeah, he's not moving.
John, are you all right? Oh, honey, wake up. John.
Ma'am, I'm a medic first aid provider. Let's try not to move him. Sir, sir, can you hear me? Are you okay, sir? Please go call 911.
Okay, please help him.
Hey, Mark, Dale's with the truck. Do we need to call dispatch?
No, his wife called 911. Can you meet the paramedics at the street? Lead him back here, please.
Hey, no problem.
Thanks, man.
They're coming. They want to know if he's breathing. He is, right?
Yes, he is, but he's unresponsive.
Yes, he's breathing, but he won't respond to us. Yes. Yes. Okay, thank you. Please hurry. They want us to keep him still until they arrive. John? John, honey?
What's going on?
Oh, he's fallen off a ladder up there.
Okay, did you get knocked out when you fell?
Apparently so. This is where he was when we found him.
Okay, Mike, why don't you go ahead and take over the airway for me? Got it? And Kyle, let's get some oxygen on him.
As a medic first aid provider who has decided to respond to an emergency, your first step in providing emergency care is to identify and treat life-threatening injuries and illnesses. In order to do this safely, you must first quickly evaluate the setting in which the person is found and make sure it is safe for you and others to enter. An emergency scene can be dangerous for you as a rescuer. Using the acronym SETUP can help you recall important aspects of scene safety. The S stands for stop. Pause for a moment. Review the scene. Is the scene hazardous? Is it the reason the person became a victim? If so, you must protect yourself against becoming a victim too. Also, consider the forces involved. The manner in which a person was injured can help you decide if you need to modify the way you handle and care for the patient. E stands for environment. Environment includes the conditions, circumstances, and influences affecting the scene. Consider the environment the patient is in. Are any environmental hazards present? T stands for traffic. Hundreds of people, including public safety workers, are struck and killed every year as they work outside disabled vehicles. Use extreme caution. Remain constantly alert to the dangers of traffic. The U stands for unknown hazard. Unknown hazards are those that are not readily apparent. They include toxic gas, lack of oxygen in the atmosphere, spilled materials, structures that may collapse, and potentially explosive environments. Consider the potential for unknown hazards before proceeding. P stands for protect yourself and the patient. Medic first aid providers can be exposed to infectious diseases when caring for ill or injured patients. Take the time to isolate yourself from body substances with protective barriers, such as gloves, face splash guards, or resuscitation masks. Remember, in all cases, your safety and well-being come first. Some situations may simply be beyond your ability to help. If the scene is not safe, do not enter. In these cases, calling emergency medical services, or EMS, and letting them handle the situation is the best way to help the ill or injured person. After assuring the scene is safe, approach the patient. As you do, notice if the patient is still or moving around, awake or apparently unresponsive, obviously injured or bleeding. Introduce yourself and say, "I'm a medic first aid provider." Do this even if the patient seems unresponsive. He may not be completely unconscious and may be able to respond in some meaningful way. If there is no response to your voice, try to use physical touch to get a response from the patient. Tap or gently shake the patient's shoulder and shout, "Are you okay?" Any patient who is unresponsive should be considered to be in a life-threatening condition and should receive immediate bystander care and access to professional emergency medical services. The emergency medical services system should be activated as soon as you recognize an ill or injured person is unresponsive or that an emergency exists. Activating EMS is usually as simple as dialing an emergency telephone number. Scenarios in this program use 911, the universal emergency number in the United States and Canada. Emergency numbers vary among countries, but are typically easy to remember 3-digit numbers. Additionally, some occupational settings have specialized emergency response plans in place, including the use of in-house emergency response teams. These emergency plans may use different numbers or procedures to notify response team members and EMS. Taking time to become familiar with emergency numbers and procedures at work and while traveling plays an essential role in preparing for medical emergencies. If the patient does not respond to your voice or touch, assess the airway. The airway is the passageway between the patient's mouth and lungs. The airway must be open so air can enter and leave the lungs freely. Blockage of the airway is most commonly caused by the tongue. When a patient is unresponsive, all the muscles relax, including those in the jaw. Because the tongue is attached to the jaw, the base of the tongue falls against the back of the throat and blocks the airway. This must be corrected in order for the patient to live. Airways blocked by the tongue can be cleared by physically moving the head to bring the jaw forward. Research indicates the combination of tilting the head back and lifting the chin provides the most effective approach to opening an airway blocked by the tongue. In this patient's case, there may be serious injuries to the head, neck, or back. If a patient's head is turned slightly to one side, place one hand on the forehead. Gently move it into a neutral position in line with the rest of the body. An attempt must be made to establish an airway with a minimal amount of movement out of the neutral position. Techniques such as the chin lift maneuver or jaw thrust move the jaw forward without tilting the head. If the use of the chin lift or jaw thrust is unsuccessful, the head should be tilted backward slightly to open the airway. Even when there is a potential spinal injury, it is vital to understand a patient must have an open airway in order to breathe and live. After opening the airway, quickly inspect the mouth. An unresponsive person may have fluids or solids in the mouth that can also block the airway. If foreign material is visible in the mouth, it must be removed immediately. Since the patient's mouth is clear and the airway is open, the next step will be to assess breathing. Adequate breathing occurs when inhaled air is drawn into the small air sacs in the lungs, creating a clear and regular rise of the chest, along with a measurable exhalation. Inadequate breathing can be recognized by noticeable but very weak gasping, shallow or sometimes irregular efforts to breathe. Inadequate breathing provides no usable oxygen for the patient. With the airway open and clear, Assess for breathing with a technique known as look, listen, and feel. Place your ear close to the patient's nose and mouth. Look for the chest to rise and fall. Listen for sounds of breathing. Feel for the flow of any exhaled air on your cheek. Take no longer than 10 seconds to assess for breathing. If breathing is absent or inadequate, you would provide 2 rescue breaths for the patient before moving on to assess circulation. Since this patient is breathing, indicating a heartbeat is present, it is not necessary to check for additional signs of circulation. If breathing was absent, the medic first aid provider would give 2 rescue breaths before assessing circulation. Signs of circulation include return of breathing, patient movement, coughing, and an obvious pulse in the neck. If these signs were absent, the patient would require CPR. Continue your initial assessment by scanning for serious bleeding. In some situations, bleeding can be rapid, quickly leading to shock and death. Bleeding must be controlled as soon as the patient's airway is cleared and adequate breathing has been assured. The last step in your initial assessment is to assess the patient's tissue color and temperature. Tissue color depends on the amount of blood circulating in the vessels of the skin. In deeply pigmented patients, color changes resulting from illness or injury may not be obvious. However, changes in tissue color can be seen in all patients in the lips or fingernail beds. Normal tissue color is pink. Abnormal skin appearance, such as blue, very pale, or bloodless, indicates poor circulation or a serious lack of oxygen. Assess the skin temperature by touching the patient's skin with your exposed wrist, taking care to isolate yourself from any potentially infectious body fluids. Normal skin temperature is warm and dry. As long as the patient remains unresponsive, you must continue to maintain the airway in an open position without moving the head or neck. If a second rescuer is available and EMS has been activated, he or she can assist you by holding the patient's head still. Make certain the patient continues to breathe normally, at least 10 to 12 times per minute. Recheck wounds and assure all serious bleeding is controlled. Monitor tissue color and temperature. Do not move the patient unless absolutely necessary. Relay information when turning the patient over to the responding EMS providers. This should include what happened, the patient's initial condition, the care you provided, and any changes that have occurred in the patient's condition. As a medic first aid provider, your decision to provide initial assessment and care is not only a valuable and compassionate act, it is the essential first step in helping to assure continuity of care between yourself and professional healthcare providers.
So far, you have learned that initial assessment is the first evaluation of both the scene and the patient. This includes using setup, assessing responsiveness, and activating EMS or an appropriate emergency care plan. You have also learned how to initially assess the airway, breathing, and circulation in an injured or ill person. We can now begin to focus on the life-threatening problems that affect the airway, breathing, and circulation. Let's start with a focus on the airway. The airway is the passage that allows the movement of air between the mouth and lungs. One of the most important early actions a medic first aid provider can perform is establishing and maintaining a patient's airway. The tongue is the most common cause of airway obstruction. Unresponsive patients typically lose muscle tone. When this occurs, it's possible for the base of their tongue to relax far enough to block the airway. Since the tongue is attached to the lower jaw, moving the jaw forward lifts the tongue away from the back of the throat and unblocks the airway. This can be accomplished by several methods. If you do not suspect injury to the head, neck, or back, open the airway of an unresponsive person by using the head tilt, chin lift airway technique. To perform the head tilt, chin lift maneuver, place one hand on the forehead. Place the fingertips of the other hand under the bony part of the chin. Apply firm, backward pressure on the forehead while lifting the chin up and forward. This should tilt the head back and move the jaw forward. Maintain the head tilt with the hand on the forehead. Continue to support the bony part of the jaw with your fingers. The fingers should not press deeply into the soft tissue of the chin. This can also block the airway. Do not use the thumb to lift the chin. Leave the mouth slightly open so you may inspect it. When an injury is suspected, or you are uncertain whether the patient is injured, you should attempt to open an airway without tilting the head. Use a chin lift or a jaw thrust maneuver. To perform a chin lift without head tilt, use one hand on the forehead to maintain the head in a neutral position. Place the fingertips of the other hand under the lower jaw on the bony part and gently lift the chin. The jaw thrust maneuver is performed by lifting the jaw with the fingers of both hands hooked under the angles of the jaw. Do not tilt the head. If the chin lift alone or jaw thrust are unsuccessful in opening the airway, tilt the head backward. Solid material can also block the airway. A patient who is unresponsive or has an altered level of responsiveness may not be able to clear the airway of solids naturally. After opening the airway, inspect the mouth. With your gloved finger, quickly remove any solid objects such as pieces of vomited food, blood clots, or teeth. If you hear gurgling or the patient vomits, it means liquids or semi-liquids are endangering the airway. You must roll the patient quickly onto the side to clear the airway. Remember, a patient must have an open airway in order to live. It is possible a patient may have injuries to the head, neck, or back. To provide as much protection as possible, support the head and neck. Grasp the opposite arm near the elbow and squeeze into the patient's side. Roll the patient like a log in one piece. Try to keep the head, torso, and shoulders moving at the same time without twisting the body. Allow the fluid to flow out. You may have to remove material remaining in the mouth with a gloved finger. If required to provide ongoing care, such as rescue breathing or CPR, return the patient to his back. If not, keeping the patient on his side helps to protect the airway. The recovery position should be used to protect the airway when an unresponsive, uninjured person is breathing adequately. Raise the arm nearest to you upright against the head. Support the head and neck. Grasp the opposite arm near the elbow and squeeze into the patient's side. Roll the patient towards you in one piece and without twisting the body. With the patient on his side, move the top leg forward. Place the top hand under his head to provide stability for the body. Position the patient forward enough to assure an open airway. Monitor the patient's breathing. This position uses gravity to keep the base of the tongue forward and the airway clear. As with the log roll, any fluids in the airway will drain out of the mouth and not back into the airway. It is critical medic first aid providers recognize the importance of establishing and maintaining an airway. Without a clear and open airway, the patient will not survive. Different methods for dealing with choking are taught throughout the world. These include back blows, abdominal thrusts, and lateral chest thrusts. Abdominal thrusts, also called the Heimlich maneuver, are recommended in the United States, Canada, and many other countries. The following scenario demonstrates the use of abdominal thrusts.
Well, are you ready for a break?
Absolutely, you don't have to ask me twice.
I've been ready since an hour ago.
It's cold out there.
Yeah, the wind chill.
I take after my mother, yeah. Yeah, she's conceited too. Lonnie? Lonnie! Lonnie!
Lonnie! Lonnie, can you talk? Are you choking? I'm gonna help. Can you breathe? Keep coughing, get it out. Keep coughing. You all right? You okay? Keep coughing, get it all out. Get it all out.
Food or other solid objects can become lodged in the airway of a responsive person and block it. This is referred to as a foreign body airway obstruction, or more commonly, choking. People who are choking typically hold their hands to their throats as they attempt to clear the obstruction naturally. If you suspect a person is choking, perform the following steps. Determine if a patient can speak, breathe, or cough forcefully. If a patient can, do not interfere. If he cannot speak, breathe, or cough forcefully, or if he makes high-pitched noises while inhaling, you must act quickly or the person will become unresponsive and death will quickly follow. Stand behind the patient. Wrap your arms around his waist. Make a fist with one hand. Place the thumb side of your fist against the patient's abdomen, in the middle, just above the navel and well below the bottom of the breastbone. Grasp your fist with the other hand. Quickly thrust inward and upward. Each thrust should be separate, distinct, and given with the intent of forcing the object out. Repeat the thrusts until the person can breathe normally or until they become unresponsive. If the patient loses consciousness, get him to the ground as gently and quickly as possible. Activate EMS or your specific occupational emergency plan. Begin CPR. This will be covered later in the program. If you are alone and are choking, you can perform abdominal thrusts on yourself. If this does not work, try to compress your abdomen by quickly pressing it into a chair back, railing, or similar surface.
So how was your day, honey?
Oh, pretty good.
In cases of advanced pregnancy or marked obesity, chest thrusts may be used as an alternative to abdominal thrusts.
Can you speak?
Position yourself directly behind the patient. Place your arms under the patient's armpits, encircling the chest. Place the thumb side of your fist on the middle of the breastbone. Take care not to put pressure on the ribs. Grasp your fist with your other hand and thrust backward. Continue thrusts until the person can breathe normally or until they lose consciousness. If that happens, begin CPR.
You'll be okay.
Choking does not commonly occur to patients who have experienced a submersion in water or a near drowning. Water does not act as a foreign body to obstruct the airway. You should immediately provide rescue breathing or CPR for submersion victims. Abdominal thrusts can cause internal injuries. They should never be given unless clearly necessary. However, when required, they can be life-saving. A patient who has experienced a complete airway obstruction that was removed by abdominal or chest thrusts should be evaluated by EMS and seen by a physician to assure no internal injuries resulted from the event. You now know how to perform initial assessment, including using setup, assessing responsiveness, and activating EMS or an appropriate emergency care plan. You have learned how to initially assess the airway, breathing, and circulation in a person who is injured or ill. You have also learned how to care for problems with the airway, such as clearing the tongue, clearing solid material, clearing fluids, positioning a patient to protect the airway, and clearing the obstructed airway of a choking patient. Now that you've learned how to manage the airway, let's focus on breathing. Breathing is the action of taking in and using oxygen. Each cell of the body requires a regular supply of oxygen in order to stay alive. Because the body cannot store oxygen as it does with food and water, we must continually breathe oxygen into the lungs. The air we inhale contains approximately 21% oxygen. Negative pressure created by the expansion of the chest draws in this oxygenated air, which flows through the airway and into the lungs. In the lungs, oxygen is absorbed into the bloodstream and circulated throughout the body. Carbon dioxide, created as a waste product in the process, is released in the exhaled air. Not all of the oxygen is used by the body in the breathing process. Exhaled air contains about 16 to 17% oxygen. It is enough oxygen delivered during rescue breathing to support life. Ventilations are artificial rescue breaths given to patients who are not breathing or who are not breathing adequately. Rescue breaths are given by blowing exhaled air through a barrier and into a patient's lungs, inflating them. When delivering ventilations, rescuers must pay attention to both the volume and the pressure of the breaths they give. Excessive volume or pressure can cause air to become trapped in the stomach. This decreases the effectiveness of the ventilations and increases the chance the patient will vomit. Correct volume and pressure can be judged by watching the chest rise. A slow, even rise of the chest over 2 seconds provides adequate ventilation with minimum volume, pressure, and complication. To reduce your exposure to infectious disease, always use a protective barrier device, such as a face shield or ventilation mask, when giving ventilations. When using a face shield, place the opening on the shield over the mouth and establish an open airway. Seal the patient's nose by pinching the nostrils closed. Take a deep breath. Press down on the shield with your mouth to create an airtight seal and blow through the opening. The delivery time of each ventilation should be 2 seconds. Ventilations should be slow, smooth, and even. Each one must visibly raise the chest. Remove your mouth from the shield after each ventilation. Allow the patient to completely exhale. Take a fresh breath in preparation for the next ventilation. Using a mask requires a slightly different approach. Place the top of the mask over the bridge of the nose. The rest of the mask should lie naturally on the patient's face, covering her mouth. Using your hand on the patient's forehead, form your thumb and forefinger into a V shape to control the top of the mask. Use the thumb of the hand lifting the chin to control the bottom. Open the airway. Seal the mask against the patient's face by pushing it down. Take a deep breath. Put your mouth around the one-way valve and blow until the chest rises. Remove your mouth. Allow the patient to completely exhale. Remember, blowing in too much air can cause vomiting. Limiting ventilation volume and pressure helps to avoid this problem.
Attention please. Will the emergency response team please respond to a medical emergency at the central heating station, north side, unit 5. Medical emergency
Hurry. We don't know if Ryan's breathing.
Is it okay? His name's Ryan?
Yeah.
Ryan! Ryan, my name's Chris. I'm with the emergency response team. Hey, Ryan, can you hear me? Ryan? Do you think he fell and got hurt?
No, the screen was on the floor and he's on his hands and knees when I found him.
Okay. He's not breathing. Do you have your mask handy?
Yes. Here you go.
Thanks. He's got a good strong pulse, but he's still not breathing.
The fire department is on site and on the way to the heating station.
Thanks for letting us know.
Yeah, I'll go meet him and lead him on in.
Whenever you recognize an emergency exists, it is imperative to assure the scene is safe. EMS, or an established occupational emergency plan, should be activated without delay. When you reach the patient, introduce yourself and see if he responds. If there is no response, physically tap or gently shake his shoulder. In a loud voice, ask, "Are you okay?" Assess the airway. If you have no reason to suspect a head or neck injury, open the airway by tilting the head back and lifting the chin. Inspect the mouth for fluids or solids that might block it. If the mouth is clear, assess breathing. Look, listen, and feel for breathing. If breathing is absent or inadequate, you will need to breathe for the patient. Inadequate breathing can be recognized by noticeable but very weak gasping, shallow or sometimes irregular efforts to breathe. If you are not positive within 10 seconds that breathing is adequate, give rescue breathing immediately. Place a barrier. While maintaining an open airway, take a deep breath. Place your mouth over the barrier and attempt a breath. If your attempts to give rescue breaths are not successful initially or at any time during resuscitation, assure a good head tilt chin lift and try again. It is appropriate to give between 2 and 5 initial breaths. In the United States, 2 slow breaths are recommended. Following the breaths, assess for signs of circulation. This patient definitely has a pulse and is not bleeding. However, most importantly, he is not breathing. The medic first aid provider must continue to perform rescue breathing or the patient's heart will stop beating and he will die. Rescue breathing is given at a rate of approximately 10 to 12 breaths per minute, or 1 each 4 or 5 seconds. The delivery time of each breath should be 2 seconds. After giving each breath, take a breath of fresh air. Remember to allow the patient to completely exhale between rescue breaths. If your breaths are adequately inflating the lungs, you will clearly see the chest rise and fall. Monitor the patient's signs of circulation to assure his heart continues to beat. Breathe for the patient until he resumes breathing on his own, or until another qualified rescuer or EMS provider takes over. Let's review what you've learned up to now. In initial assessment, you learned to assess the scene using setup, how to assess responsiveness, and how to activate EMS, or an appropriate emergency care plan. You've also discovered how to initially assess the airway, breathing, and circulation. You've learned to assess and care for problems affecting the airway. You've also learned how to manage problems affecting breathing, such as ventilating with a barrier device and providing rescue breathing for a patient with inadequate or absent breathing. Let's move on now and focus on circulation. Circulation is the distribution of blood, oxygen, and nutrients, and the removal of cellular waste products by the heart, lungs, and the bloodstream. The body's circulatory system is a complex arrangement of connected blood vessels. The driving force of the system is the heart. Blood circulates under pressure created by the heart's mechanical contractions. Large vessels called arteries carry oxygenated blood from the heart to body tissues. Veins return used or deoxygenated blood to the heart. From there, used blood is delivered to the lungs where carbon dioxide is released and fresh oxygen picked up. Fresh oxygenated blood is returned to the heart and the cycle repeats. Special tissue runs throughout the heart that is capable of creating and conducting electric current. It is this electrical current that triggers the rhythmic mechanical contractions that create blood flow. Disruption of this electrical process can result in the loss of contractions and blood movement. This is called cardiac arrest. The body cannot survive when circulation stops. Brain tissue is very sensitive to the lack of oxygen, which occurs during cardiac arrest. Brain damage begins 4 minutes after the ill or injured person's circulation stops and generally becomes unsurvivable within 10 minutes. Complication with the heart's electrical system, often due to cardiovascular disease, is a major cause of cardiac arrest. Other common causes of cardiac arrest include breathing stoppage, blocked airway, severe blood loss, electrical shock, overdose, severe allergic reaction, and drowning. Regardless of the cause, a medic first aid provider's emergency care for cardiac arrest is the same: cardiopulmonary resuscitation, or CPR. CPR artificially oxygenates and circulates blood through a combination of ventilations and external chest compressions. External compression of the chest has been proven to move blood to the heart and brain. However, blood flow during CPR is very limited and greatly influenced by the quality of chest compression. To make blood flow to the heart and brain effective, the patient must be face up and lying flat on a firm surface during chest compressions. To perform compressions, you should kneel next to the patient's chest. Place the heel of one hand on the center of the breastbone between the nipples with the other hand on top of the first. You may interlace your fingers to help maintain position. Your knees should be placed a shoulder's width apart and as close to the patient as possible. When ready, bring your body up and forward to the point where your shoulders are directly above your hands. Lock your elbows and shoulders and use your upper body weight to help compress the chest. Push straight down to a depth of 1.5 to 2 inches, or 4 to 5 centimeters for an average adult. Keep your shoulders straight above the center of the chest. Release pressure and completely remove your weight at the top of each compression. Do not allow your hands to lose contact with the chest wall. Without pausing, continue into the downstroke of the next compression. Continue chest compression in this manner at a rate of approximately 100 times per minute. You will make blood flow as effective as possible by doing the following. Use your upper body weight to deliver the recommended force with smooth, fluid movements of equal duration during compression and release of the chest, and by maintaining the correct rate during CPR.
Thank you. Appreciate it. Hi. Are you ready to go to the meeting? Oh, forgot. That's right. Let's go. Are you feeling okay? I'm fine. I'm tired. Actually, I think it's something I ate last night. I don't feel very good.
Hey, Christine.
Good morning.
Oh, hi, how you doing?
I'm fine.
I want to take this chart, try to consolidate it down so we don't have so much of this going on. Is that going to be okay? Christine? Christine, it's Mike. I can help you. Are you okay? Are you okay? She's not conscious. Go call an ambulance now.
Right, okay.
Christine collapses. She's not responsive. Go get the AED.
Okay, I'll get it.
Hello? Yes. We have a woman who's collapsed and she's not moving and she's not responding to us. Our address? Our address is 25628 Wagner Drive. Our company is OB Media. Yes, yes, that's correct. I'm sorry?
3, 4, 5,
Oh, I don't
6,
know, but I
7,
can ask.
8, 9, 10,
They want to know if
11,
she's
12,
responsive and breathing.
15. She's not breathing. She has no pulse. We're doing CPR and getting our AED.
She's not breathing. They're doing CPR and getting our AED now. They want someone to meet them in front of the building.
Okay, I can go. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. There's no circulation. Go ahead and hook it up.
Okay, I'm gonna need a bare chest. If I'll get you some scissors.
Apply pads to patient's bare chest. Plug in pads connector next to flashing light. Apply pads. Plug in connector. Analyzing heart rhythm.
The most common medical emergency in industrialized nations around the world is sudden cardiac death, primarily caused as a complication of heart disease. Blood circulated to the lungs by CPR, a combination of effective rescue breaths and chest compressions, carries enough oxygen to keep the brain and heart alive for a limited period of time. Persons suffering sudden death have no obvious signs of life and must be cared for immediately to allow any chance of survival. It is useful to realize a patient in cardiac arrest is essentially dead. No further harm can be done attempting to resuscitate one who seems deceased. Remember setup. Make sure it is safe for you and others to care for the patient. Introduce yourself and state your level of training. If there is no response to your voice, tap or gently shake the person's shoulder. Speaking loudly, say, "Are you okay?" If there is no response from the patient and there is another person available, have them activate EMS or your organization's emergency response plan. If you are alone with an unresponsive patient, you should leave the patient to call for help. Return as quickly as possible. Protect yourself and the patient by using appropriate barriers to isolate yourself from any body substances. If barriers are not immediately available or you're unwilling or unable to provide mouth-to-mouth rescue breathing, it is better to do chest compression only CPR than to do nothing. Assess the airway and breathing. If there is no reason to suspect head or neck injury, open the airway with the head tilt, chin lift. If material is visible in the mouth, remove it. Look, listen, and feel for breathing. If breathing is absent, apply an appropriate barrier and give 2 slow rescue breaths. Make sure to give large enough breaths to inflate the lungs and make the chest rise, but no more than that. Continue by assessing for signs of circulation. Look for breathing, coughing, or movement in response to your rescue breaths, and check the pulse in the neck. If, within 10 seconds, you are not positive that signs of circulation are present, proceed immediately to chest compressions. Position yourself at the patient's side. Locate correct hand placement and begin compressions at a rate of 100 compressions per minute. After 15 compressions, move up to the patient's head and open the airway. Give 2 slow rescue breaths, creating a visible chest rise with each breath. After completing 4 cycles of 15 compressions and 2 breaths, stop CPR. Check for the return of any signs of circulation. If circulation signs are still absent after 10 seconds, resume CPR. In some countries, stopping to reassess for signs of circulation may be recommended only if the patient shows signs of recovery. Continue CPR. Stop and check for return of signs of circulation every few minutes until someone with equal or higher training relieves you, until you are exhausted and unable to continue, or in the rare case when signs of circulation return. If signs of circulation do return, check immediately for normal breathing. If breathing is present, place the patient in the recovery position and continue to monitor his breathing. If the patient is not breathing or is breathing inadequately and signs of circulation are present, provide rescue breathing and monitor signs of circulation for any change. Adequately and signs of circulation are present, provide rescue breathing and monitor signs of circulation for any change.